Yeah, so I am here to tell you about the implementation story. And I'm very happy to be here. So this talk will be focusing on development and initial testing of a pilot family and nurse presence on rounds audit tool. And the purpose of this project was to describe the development and initial testing of a pilot family and nurse presence on rounds audit tool utilizing interdisciplinary rounds in a 13-bed intensive care unit at a 350-bed teaching hospital in Southern California. The pilot project goal was to provide attending physicians and staff nurses insight regarding adherence to agreed-upon standards for family involvement and engagement during rounds. Because this kind of stuff sounds so good when you're sitting in a room, right? Like, should families be involved? And everyone nods their head yes, right? Should the nurses be engaged? Yes. Should we be collaborative? Yes. And everyone thinks, let's do it, right? So that's what this project is about. So let me just tell you a little bit about this particular unit where we did this. There are 80 RNs in this unit, and there are 2 primary medical teams. There are 15 pulmonary critical care attendings, 3 neurocritical care attendings. There's fellows, there's residents, there's service-specific NPs, PAs, clinical nurse specialists, social worker, respiratory therapists, graduate students, nursing students. A very, as you might expect, what a teaching hospital would look like. The rounding model with multidisciplinary rounds, people who are present on rounds, the ideal group that we would like to have present on rounds are listed here. Ideally, the RN is an active member of rounds and part of the interdisciplinary team and recognized as part of that team. Ideally, the patients and families are recognized in partners in care for their partnership in care and recognized for all that they can contribute, given the fact that they know the patient better than anyone else. I always go back to the concept that we are the visitors in the patient's life, right? The patients, the family members of the patients are not the visitors, we are. So the traditional format of how rounds have always been done in this unit for years and years is that it is traditionally led by the attending MD. And the residents start rounds, and the RNs interject if they're assertive, but usually what happens is that there's a big group of people in white coats standing there. This particular unit has individualized patients' rooms with glass doors in each room. Sometimes, some of the teams, the family would be right on the other side of the door, and sometimes, not routinely, but occasionally, the door would just be shut. The glass door would be shut. The family would be sitting right there. The patient would be in there. We could see them. They could see us. Yet, there we were outside of the room talking about what's going on with the family. Typically, or what's going on with the patient and the family. The residents present, and God bless the residents, really. I mean, honestly, the units are so busy and they work so hard. Now, consider the view from the resident who perhaps has been up all night. It's been really busy. It's been a busy night, perhaps a lot of STEMIs, a lot of stroke codes, whatever is going on in the unit. They do a quick run, they catch up on all their patients around 6 or 7 in the morning, but in a teaching hospital, in this kind of unit, sometimes rounds take a long time. So perhaps the resident has looked at the patient at 6 or 7 in the morning and checked in with the nurse and said, okay, what drips is he on? What are his vital signs? What are his latest labs? And they write that all down, right? Then they come to rounds perhaps 2 hours later, sometimes 3 hours later, and they will so occasionally say, all right, the patient is on this much of Levophed, this much of neosynephrine, and the nurse will be like, no, really, he's only on 100 of neo. And then they'll say, the MAP is 50. No, really, the MAP is 70. So they're, although in theory it seemed as if the nurse was a equal member of the team, in practice that wasn't always perceived that way by nurses. So the nurses typically would stand outside of the circle, depending on how assertive they are and how big they were too. Sometimes they would work the way into the circle. And they every now and then they would interject, no, really, it's this, or no, really, it's this. Or sometimes they would wait until the end of rounds and say, okay, let me just tell you right now the NEO is at this and the map is that. So it causes sort of a backward communication. And traditionally, families were not included. So process issues with the traditional format. Missing healthcare members cause questions to remain unanswered. The other challenge here is that in this particular unit, I told you there are 2 different services. And so it's typical that the nurse would have 2 different patients, sometimes 2 different patients on 2 different services. So the nurse can't be the same, the same place at the same time, 2 different places at the same time. Discharge process is sometimes held up because of missing members. Like, we don't know what the plan is because not everyone who should be at rounds is on rounds. And there's variation in round start time, and sometimes it's just waiting for other team members to show up. With the new rules about the residents, they need to be out of the hospital if they were on call the night before by 11 o'clock. So even though this is a 13-bed unit, what may seem logical that you'd go from bed 1 to bed 13, sometimes that isn't how it goes. The resident who needs to get out of there goes first. So we may round on bed 1 and then on bed 10 and then on bed 7 and then on bed 13. So for the nurses and the family members to anticipate when they were showing up is always a challenge. Medical teaching is a wonderful thing, but it is also a process issue because different physicians have different styles of teaching, and some physicians take a really long time to complete rounds. Passing information to person, particularly if the nurse isn't involved in rounds, then it becomes like a telephone game. What did he say the goal was? Or if a nurse is covering for a nurse who's on break, then getting that message from that nurse to the other nurse. When families don't participate, as I'm sure you know, if they aren't participating, then you have to go and find the families afterwards to tell them what the plan of care is. So in terms of physician time, it takes more time to go and find them. And we find the families hovering outside the room. When are the doctors coming? What time did you say they were going to start? When are they going to get here? So family members are hovering, looking for the medical report. And then, as I said, the physicians have to come back later. This particular unit, in some parts of this unit, the hallways are kind of narrow, so there's limited space in the hallways. The guy with the cafeteria tray is coming and people are dispersing and you can get the setup. The medical team does not always wait for the nurses or for the ancillary staff. Although some of that is physician dependent, but the issue with that, of course, is if the nurses don't participate, they're not aware of decisions being made, and families receive one message from the physician and another message from the nurse because they have not been in communication with each other. So patient and family center rounds, the purpose is shared decision making, and the goal is family engagement, specifically with the RN leading the role in family engagement, because the RNs are the consistent people in this unit. The attending physicians rotate every couple weeks, right? And the residents rotate every 4 weeks. So who's there consistently? Well, it's the nurses. So the RN orients the family to the process, basically saying something to the effect of, you'll see people in white coats coming to the bedside. That's the interdisciplinary team. We welcome your participation in rounds. We'd love to have you involved. You're an important member of the team. This is the traditional format. If you have any questions that can be answered within a minute or two, we can answer them during rounds. Here's a pad of paper and a pencil. You can write them down. If you have questions that will take longer than that, we can set up a family meeting for you. Okay, and the family and the patient is given the option to join rounds. And they follow a relatively standardized format. And the goal here with patient and family center rounds is to have a standardized format to get away from the chaoticness that can happen with traditional rounds. So this, and I'll talk about how this was incorporated into the unit but in just a moment, but as we tried to change the format of rounds, then I had a discussion as the advanced practice nurse in the unit with the medical team about having the nurses start rounds. And I had we had brought up instances after instance after instance where the information from the residents wasn't necessarily up to date and how there was delay in implementation. So we agreed as a team to come up with the information that the nurse would share at the start of rounds, including vital signs, hemodynamic strips, sedate, daily awakening, CAM ICU lines, airway, and so on, including any of the family members who were present to introduce them to the rest of the team. So the RN was supposed to update the team on the patient's current status. Then the resident was going to follow that by presenting data, followed by discussion of physiology, meds, vent settings, etc. by the team. And then family questions and input were encouraged, as I had discussed. And then the plan of care was developed collaboratively. We all said, all right, this is the plan of care, and off we went. Doesn't that sound great? Like, wouldn't it be great if that really happened every single time? Perhaps in some of your units it does. And I wish I could say that that was true here. So the sequence of events is we had a user meeting. There's something called a users meeting, which is everyone who uses this particular unit. So the physicians, the nurses, the social worker, all agreed that we would try this format for rounds. Got buy-in from everyone about the format that we had just talked about. Okay, let's do it. We did training with the nurses. We went to the Quality Council for the nursing group. We had a staff nurse leader for this project because peer pressure is more effective than anything that can come from me. So it was development of staff to have this happen. Everyone was gung-ho about it. Keeping with the concept of change theory, though, oops, this isn't clicking past. Oops. Keeping with the concept of change theory, though recognizing that change doesn't happen because everyone sits in a meeting and says, okay, let's make this happen, right? So what I did then is I cleared my schedule for mornings for about 5 months and did rounds every single morning. And every single morning, as the team switched, I tried to reinforce what the team had agreed upon. Again, consistency is important, and as I mentioned, the attendings rotate, the residents rotate. So what seemed like a really easy, I wasn't naive enough to think it would be easy, but what seemed as if it was just an agreed upon concept really was very difficult. And I found myself in the role of the advanced practice nurse in the unit of being kind of like an orchestra leader, or a stage director or something. It's like, wait, no, you don't talk yet. Nurse, where's the nurse? Here she is. Okay, nurse, you're on. Okay, now, resident, okay, now attending, okay, and here's the family, right? And so, and just as we would get one attending group on board with doing it, then they would switch. Then it would be the next attending group. And then that attending wouldn't be back for a few more months. And by that time, they had been falling back into old habits. So it was a constant, somewhat frustrating struggle. And the staff, and there were days that after rounds I would say, and I would notice things in rounds like, like the nurse talking and the physician talking at the same time, or not paying attention, or sidebar conversations when the nurse was talking but not necessarily when the physician was talking. Or sometimes the nurses were being disrespectful when the physicians were talking and doing the same things, having sidebar conversations. I am, as I'm sure you are, aware of the literature on lateral violence. That's what came to my mind as I was watching some of the somewhat disrespectful behavior. For example, I noticed during this time when I was, orchestrating this, that some physicians would make eye contact with nurses and some physicians wouldn't. They'd look at their paper. Okay, yeah, that's right. The nurse has to go. Go ahead. Right? And then the physician would go and they would pay more attention. And I don't want to give the impression that I don't have a collaborative team because I can't say enough good things about the physicians I work in. This is just I work with. This is just a story of old habits dying hard. So the sequence of events, months and months and months of this. And then at the end of rounds, I'd say to the attending, so how do you think it went? And they'd say, I think it was great. I think it went really good. And I'd be like, really? Really? You think that went really well? And so then that led down the road. We did a survey of the physicians and the nurses for their perception of collaboration in rounds. And the majority of the physicians surveyed of the attendings that were in the unit said that they were very collaborative, yet the nurses' feedback was they didn't feel like part of rounds and they didn't feel as if it was as collaborative as they would like. So it was clear to me that there were some, misperceptions. So then I thought, all right, so I am standing in rounds every day doing this orchestration, and yet there are still all of these problems. So I thought perhaps it would be more valuable if I had someone do anonymous observations in rounds. So I enlisted the help of my graduate students. And based on just observations during, my time orchestrating rounds, we came up with this audit tool. And I recognized all the weaknesses in this audit tool. It does not have reliability and validity. It is just based on my observations. So I throw it out there that I recognize the weaknesses of this. But simply the questions were the RN present? Was the RN physically in the circle? Because again, thinking about some of the lateral violence information about the circle sometimes would get smaller when the family came in or when the RN came in. Did the RN speak? Did the attending MD ask questions of the RN? Did they make eye contact with the RN? And that's based on some of the lateral violence stuff. Were the family present? And if they were present, did anyone talk to them? Were they included? And then there was a spot for additional observations for the graduate students to make. So the inter-rater reliability with the graduate students was developed with me and the graduate student, and also with graduate student and graduate student. So I would round with them one day, right, go over it with them, then ensure that we're all measuring the same way. So baseline data was collected during 176 patient round episodes with 12 different attending physicians over a period of 2 years. And these, and again, I fully recognize the weaknesses of this, but this is just that audit tool. So there are different physicians here who are labeled just by letter, and this is just percentage of time the RN was present. So you can see that there is an issue there with RNs not consistently being present. Was the RN physically in the circle? Again, some of it was, you can see there was differences among attendings. Attending MD asked questions of the RN, and I won't go into. If the family present, were they included? And you can see there was just a couple of physicians that included the physicians. Eye contact made with the RN, generally that happened. And then there were a number of additional observations. I think the additional observations are more telling than other things in terms of where we're going to go with this project next. So additional observations included the RN arrived late and was shaking her head no to certain things. She did not have verbal input. No one asked, and she did not offer additional information. It gets back to the importance of educating nurses about communication and giving them the confidence to communicate. I often talk, when I do classes with the nurses, I often talk about, what called the imposter syndrome, like where it is just a matter of giving them the confidence. You are smart, you are capable. You know what you're talking about. You've worked in the ICU for 20 years. How can you tell me that you're not feeling confident speaking up in rounds? So it is a lot of confidence building for the staff. Family arrived at the end, and the nurse greeted and included them. The residents held sidebars with the RN and then pulled the RN out of rounds briefly. And again, these are the graduate student observations. Attending MD interaction with patient and family was very inclusive. Eye contact, hands on the wife's shoulder, information sharing. As opposed to family was present, but no one invited or greeted them. At one point, they were asked what they thought of the patient's mental status. RN was in and out of rounds caring for the second patient. So the best laid plans, right? Ideally, the nurse would stay in rounds. Ideally, the family would be included. Ideally, this all would have been explained to the family. Additional observations. Family of the other patient started listening but then walked away. No one asked them to provide privacy. So just another patient who was wondering, I wonder what's wrong with that patient over there. Family was present in the room but not asked to join rounds. RN was covering for another RN and said she didn't know the patient because she was just covering. That happened. I don't really know what's going on. He's just covering. So when we got the physicians up to the point of, where's the nurse? I'm asking for the nurse. And then the nurse would say, I don't really know what's going on. I'm just covering. So you can see lots of opportunities. RN was on break. Attending MD rolled his eyes when told the covering nurse would be right there. And again, imagine the perspective of the graduate student. It's important to point out that these were anonymous observations. So the team thought that this graduate student was there just soaking in the wisdom of rounds, when in fact the graduate student was there critiquing rounds. So which is not necessarily the best model. Family was greeted by the MP, the exam was done at the bedside, doors were closed for privacy, and family were included in the discussion. Yay, so some great things happening. Resident asked the RN questions outside of the circle, then moved back into the circle to present the information the RN had given him. Resident made eye contact with RN. Attending MD never made eye contact with RN. Male RN with strong presence involved himself in the discussion. RN excluded from the team circle. I don't know if this ever happens in your unit, but sometimes I think perhaps part of this in discussion with the team in this unit, there's always concerns about HIPAA, right? So sometimes what happens is that the resident will stand about this close to the attending and they'll talk in a tone of voice like this. So everyone's like, what? What did he say? Did he say the sodium was what? Right? So it is a matter of like the size of the circle and ensuring that the nurse and the family member are in the circle for that particular patient, as opposed to the other residents who are there on rounds who aren't necessarily presenting that patient. Family attempted to be included. And again, these are grad student observations. I don't know if the family was included or not, but it looked like the family was trying and not necessarily included. Family present and not included. Team asked, is there anything else, as they were walking away? Like, is there anything else? And so in terms of feeling inclusive, if you were the family member standing there thinking, do they really want to know if there's anything else? Do they really want to know if there's anything else I have to say? Family present and not included. The door to the room was shut between the rounding team and the family. And then the attending MD would not start rounds unless the RN was present. So great variability. Needless to say, and I throw this out there were a million limitations to this. When I started this project, I didn't anticipate being at SCCM talking about it, right? When I started this project, I wanted to take the information from the literature and the information from patient and family-centered care and apply it to clinical practice. Seems straightforward enough. There's great many limitations. It was a non-validated tool. The attending MDs rotate through the unit on an irregular basis. Of the 12 attendings observed, some had 50 graduate student observations and some only had 5, right? So it's not like we can look at that. Attending MDs from 2 services were observed, and these 2 different services have very different cultures. They're very different in their approach to the world. I think it's worth pointing out that on one of the services, the director of that service is young and is very engaged, will not start unless the nurse is present. Like that was how she learned when she was in school. That's how she learned where she came from, and that was her expectation. And so that's what happened. Okay. A huge limitation is the individual RN behavior wasn't tracked. It was pretty presumptuous of me in putting this together with the graduate students to say, well, let's look at those physicians, right? Without saying, well, heck, there's an awful lot that nursing needs to improve on. And that this project helped bring that to play. And again, it was an anonymous observation, and there was lack of immediate feedback. When I was doing rounds with the team, I tried to do immediate feedback, but when the graduate students were doing it, that wasn't happening. So the next steps are overcoming the barriers. Report outcomes to individual. Our goal is to develop an IRB project with one of the attending MDs on the service so that we'll do it collaboratively. And to report outcomes to individual stakeholders, but to keep them blinded to the identity of others. Inform the MDs and the staff of research on the topic, post signs, report at committees, let everyone know what's happening so that the expectation of what's supposed to be happening will be posted all over the unit. Provide education, provide education, provide education, provide education. And specifically, peer pressure is more effective than anything else. So in terms of, I always look for the champions, right? Find the attending champions, find the staff champions. Modify the tool to include nurse-sensitive indicators, and modify the tool to ensure that 80% of the day shift staff RNs and the primary service attendings MDs who use the unit or audit it, and then engage the patients and families in the process in terms of the critique of the tool and discussion at those user meetings that I was talking about, and ensuring that patients and families participate in those. Overcoming barriers, change is difficult with engagement with families. Family-friendly timing of rounds on evenings. You know, as I mentioned, the rounds on days, when they start and the order in which they go is very erratic. So families who want to participate in rounds sometimes have to hang around the unit for 3 hours before they get to their patient. So the suggestion has been made to, why don't we do rounds at 8:30 at night or at 8 o'clock at night? You know, the evening rounds are usually done at 11:30 at night before the residents go to bed, but why don't we do them at 8:30 at night when the families perhaps can participate, and or 8 o'clock at night? Provide writing tablets for families, enhance family education regarding rounds, and then we, of course, need to deal with the acuity of the patient and RN engagement, because if the patient is crashing and burning, then the nurse is at the bedside with the patient and not otherwise. And ideally, rounds, of course, should be happening at the bedside. Two patient assignments in RN engagement is an ongoing issue that we're going to have to come. Break coverage in RN engagement is another issue. Part of this is just handoff communication and reminding the nurses that it's not okay to just give a report that says, he's about the same. What does that mean? Like, what are the goals while you're gone? Documentation on the plan of care, MD awareness of RN assignments, so they know, they can say, oh, okay, so Judy has this patient, so I'm going to this bedside next, so where's Judy, right? And so that they can call the nurse by name and ask for that nurse by name. It increases relationship. And then, again, another issue is the MD rounding in non-sequential order, which probably will continue based on the residency hour requirements, but there are strategies that we have to combat that.